Welcome to the Mini Medical School podcast, where we dive into the world of medicine. I'm your host, Kane, a second-year medical student, and my guest today is Dr. Rossana Rosa, an infectious disease specialist. She's an infectious disease consultant in Fredericton, New Brunswick, and is a regional infectious disease medical director for Horizon Health. She recently presented the Dalhousie Mini Medical School, and the title was When the Answer is Not an Antibiotic. Can you tell our listeners a bit about yourself and your specialty?
Yeah. Hi. Thank you very much for having me here today. I'm Rossana. Like you said, I'm an infectious diseases doctor. I am originally from Honduras, and then I moved to the US, lived there for a while, and then I moved to Canada in 2023, and now I'm here in the Maritimes.
Oh, that sounds really exciting. What do you find to be the biggest difference between Honduras and Canada?
Besides the weather.
Besides the weather, yeah.
Um, Yeah, probably that, the weather, Yeah, I think that, well, and people speak English, I guess. My mother tongue is Spanish. But other than that, I mean, I don't know. People are nice, they're friendly, and I like that. So yeah, it has been a relatively easy adjustment. I moved here from Miami actually, which is a lot more like Honduras than here, but it's all good. It's working out.
Excellent. I'm glad you're adjusting well. So we'll get right into it. The first thing on our minds when we think about infectious disease is COVID. So how has COVID changed how we diagnose and treat common respiratory infections?
Yeah. So I'd say, I mean, what we went through in 2020 was something massive. And I would also say that the most of what we think of COVID as we saw it in 2020 is actually much different than what we see nowadays, with COVID itself, right? Back then, a completely novel virus, completely naive population. Um, and then, we were seeing a lot of people very, very sick in the hospital. We initially didn't know how to treat patients, and so a lot of, science and evidence base had to be built into how to, go about diagnosing and treating patients with COVID. We certainly saw a shift after the vaccines were introduced, in how the severity of that disease changed. And so it is not to say that there isn't COVID anymore, or that COVID is just, it's nothing. It's not like that. It's just that the the sheer volumes of people that got really, really sick and those really, really bad pneumonias and respiratory failure and whatnot have changed. So we see a spectrum. We see people for whom COVID is mild respiratory infection that, can start with a sore throat and sniffles and a cough. And then for some people, particularly for those older than 65, even more for those older than 80, or people with immunocompromising conditions or comorbidities such as diabetes, high blood pressure, things like that, that the disease can actually be more severe. So the other thing I think that's interesting about COVID, as we think of it compared to other respiratory infections or other viruses that we associate with respiratory infections or with seasonality, is that COVID actually so far has not really had a seasonality. It circulates year round. We have seen peaks in the summer and in the winter, but it's not like influenza where you have a season, at least, in Northern Hemisphere, we know when it's coming. Same for RSV. COVID does seem to be something that circulates all year round. And so therefore it is something that you actually have to think about all year round when you are evaluating a patient.
That's really interesting to think about the seasonality because quite often it gets compared to influenza. With that being said, do we ever really worry about it changing to a very infectious form of COVID anytime? or can we just be safe to assume that it follows a predictable pattern now?
Yeah, I don't think we know that it follows a predictable pattern yet. Like I said, I think this past couple of seasons we have seen summer peaks and we have seen winter peaks, but it does circulate year round. I think when we think about perhaps contagiousness, right? The biggest shift that we saw in terms of contagiousness or the number of people that would get infected with COVID from a single case was when we had that huge shift from Delta to Omicron, which was from the end of 2021 into 2022. And since then, we have seen Omicron and all of its different lineages, right? So you do always worry when there is a new variant, how much that variant is going to be able to escape the immunity that a population has acquired already, whether that was an immunity acquired through vaccination or through an infection or through what we call hybrid, which is a combination of you've both been infected and you've also been vaccinated, right? So new variants tend to have that capability to more easily escape that neutralization capacity, at least from antibodies. But the other thing that we have, so in a way, it might be, when we see these new variants arise, we could see somewhat more contagiousness, so then an increase in the number of cases. Um, Having said that, even in the cases of those new variants arising, the durability of the other parts of the immune system, like your T cells, in protecting a person from severe disease, does seem to hold up. So we would see more visits to the urgent cares or more, people missing school and work because they are sick, but perhaps the hospitals, but perhaps not many people getting so sick that need to go to the hospital.
So we still got to keep an eye on COVID.
Oh, absolutely, yes.
So beyond COVID, what other emerging diseases do you keep on the radar? What should we worried about?
Yeah, so this season in particular, this is, not an emerging infection per se or nothing new, but this influenza season has actually been a very active season. We have seen, cases, a much higher number of cases than we had seen over the past couple of years. So certainly, and the other thing that was somewhat different about this season is that the peak happened a little bit later. We would tend to see it happen, or usually you expect it to happen around end of December, early January, but this year that peak in the number of cases of influenza was certainly more delayed. So we have seen a very, very active human influenza season, I would say. Avian influenza has also been in the news. I think a few nuances to understand about avian influenza or H5N1 is that this is also not a new virus per se. It's a virus that has been circulating in the wild bird populations for many decades now. The things that are different about avian influenza that we have seen over the past year is that it has been circulating much more in commercial flocks and backyard flocks. And then particularly the other new thing that happened is that it went from birds to cows and from cows to humans. It's not a disease, it's not an infection that has gone from human to human, right? So whenever we hear about a case of avian influenza in a human patient, it's still acquired, it's still zoonotic, so they still acquired it either from bird or from cow, right? But that shift, or that not shift, but that occurrence of going from bird to cow, from cow to human, is something that was new. The other the other viral infection that made a few waves, I would say probably more like for about 4 to 6 weeks ago, was a human metapneumovirus. This is again not necessarily it's not necessarily a new virus. It's a virus that we have known also for quite a few years from now. It is a virus that is included in some of the expanded PCR respiratory panels that are available, and that is perhaps why we are picking up more and more of it, even though it's not necessarily new. And then the other virus to also keep in mind is RSV. Again, not necessarily a new virus, but a virus that certainly can cause, it's a significant cause of hospitalization in infants and can lead to severe disease in older adults.
Interesting. When thinking about some of these viruses, I understand that there's vaccines available. So what are the successes and advantages for taking some of these vaccines and their rollout, such as the RSV one?
Yeah, so I think the first thing that we always have to keep in mind is that the role of vaccines is in preventing severe disease. So that means that when you get vaccinated, it is still possible for you to go ahead and get infected, right? So, you are exposed to the virus and you acquire that initial infection. But if you are vaccinated, that means that your immune system is able to then respond and mitigate the presence of that virus so that the disease will not progress into something more severe that would require for you to go to the emergency department to be seen, or for you to go to even go to the hospital, right? So that is in general our expectation for vaccines against common respiratory viruses, is for them to protect us from severe disease, hospitalization, ICU admissions, and death. So thinking about the three main respiratory viruses that we worry about during respiratory virus season, right? Influenza, COVID, and RSV. So the influenza vaccine usually has about 30 to 50% effectiveness in decreasing your risk of severe disease and hospitalization. This may sound like just 30, 50%, and I would say still higher than zero, right? It's still not, it's not negligible, and it's still, it's still, again, protection. For COVID vaccines, this again varies by population. The biggest benefit of the COVID vaccines is seen in patients older than 65, and we have to think of that benefit as an incremental benefit. What I mean by that is that when the COVID vaccines first came out, that, we all remember those numbers are like 80, 90% vaccine effectiveness, right? Now, when we hear that the vaccine has an effectiveness also between 30 and 50%, is additional to that effectiveness from the initial series that patients received starting back in 2021. So again, it's an incremental benefit, and it's a protection from severe disease, hospitalization, death. The the quote newest vaccine in the block is the vaccine against RSV. So this is a vaccine that has been around for about a couple of years only. It's currently targeting two populations, which is women in the pregnant individuals in their last trimester of pregnancy, so that they can essentially pass on that protection to their newborns, and patients older than 60 years or that have comorbidities that put them at risk for severe disease. And the effectiveness that we are seeing for that vaccine has been ranging between 70 to 90% against severe disease, hospitalization, and death. So that is, that's a great number. And really the message here is that for, of the major respiratory viruses that we see circulating during the season are now vaccine preventable diseases. The other product to keep in mind too is not a vaccine but a monoclonal antibody called nirsevimab, which is targeted for infants entering their first RSV season, and that's also a product that has shown about 80% protection against those clinical outcomes that we really care about.
Well, that's really high, 80%.
Yeah, it's amazing. Yeah, it's great.
I wonder, is that available to a lot of patients, or does it have to meet a lot of stringent criteria?
Well, so that is, that's a fabulous question. The question of availability here in Canada is a product that is approved, but currently not available everywhere in the country. It's only available in certain provinces. So I do think that that's why it's important for all of us in healthcare to be aware of when these products become available, so that if we don't see them available, we engage in advocacy for making sure that they can be brought to where we live and practice, and we can offer it to all of our patients.
Yeah, that sounds really exciting, though, if that becomes more available to Canadians. So when we think about other options beyond vaccines, what are other underappreciated strategies that can prevent infections?
Yeah, so when we think about other strategies for preventing infections in general, washing your hands is, you can never do it enough, right? I think we're also, when we're thinking of preventing respiratory infections, there's still very much a role for masking, particularly I think at times when we see increased levels of activity of particular viruses in our community, and certainly for certain high risk populations such as older patients or immunocompromised patients, or if you are someone who cares for an immunocompromised patient or live with an immunocompromised patient, then also a role in protecting yourself, right? So again, masks, they are not perfect, but all of the measures that we take, we have to think of them as mitigating measures, right? It's a thing that we do to decrease our risk of acquiring an infection. So washing your hands, wearing a mask, if you fall into those risk categories and will be going to out in public, particularly in crowded places. Another thing to consider is also smoking, right? So smoking is something that does increase your risk for severe infections, not only as a result of having a higher risk of comorbidities such as chronic lung disease and heart disease, but also in the way that it damages the natural defenses that are built throughout your immune system, and that can help you fight off or properly respond to a viral or bacterial threat when you encounter it, right? So, and I find that oftentimes people don't understand all of the risks associated with smoking in that sense. So I think whenever we, as healthcare workers, have the opportunity to ask our patients of whether they smoke and to try to offer alternatives to it, right? This is actually another argument that we can use when we talk to them about that. There's also something to be said for things like, in general, was like keeping, what we would call healthy habits, right? A well-balanced diet, trying to exercise regularly, and trying to have, consistent sleep. These are things that if they help your body, that they will also help your immune system.
When thinking about our immune system, one thing I've heard about is our microbiome.
Mm-hmm.
Is there evidence suggesting that a person's microbiome could impact their susceptibility to certain infections?
Yeah, that's a really great question because we usually tend to think of the microbiome as, we usually think of the microbiome as what's in your gut, right? But actually, we have microbiomes throughout all of our body, and we do have a natural occurring microbiome throughout our airways, and at least in some in vitro and animal models we do know that there can be changes in that microbiome when we are exposed to certain viruses, and that microbiome itself can also be altered by exposure to antibiotics in an adverse way, right? When you're trying, you might be using an antibiotic thinking that you're only treating one bacteria, when in reality you might be impacting microbiome that is naturally existing in your airways, in your lungs, and also in your gut, and that through the signaling that they usually do with our immune system may actually result in an impaired immune response when we actually encounter either viral or bacterial pathogens.
Okay. When going back to thinking about antibiotic overuse, how do patients know? How do we qualify whether it's a viral, which there doesn't seem to be many antiviral medications available, or a bacterial?
Yeah, that's a really good question too. So, I mean, you want to start with a syndrome, right? So we think of different syndromes that a patient may present with, depending on that combination of symptoms. If someone is presenting to you with mostly, say, a runny nose, sore throat, dry cough, but they don't have a fever, you might put these patients in the category of a common cold. If they feel like it's more cough, perhaps some production in, some phlegm, some increased sputum production in that cough, but still without a fever, you might think of that more as a bronchitis. Both for common cold and bronchitis, the for common cold, the causes are viral, right? These are caused by viruses, 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 viruses. For bronchitis, the overwhelming majority, 95% plus of cases of bronchitis are also going to be caused by viruses. Once you have established a syndrome, once you have established that you don't have warning signs for something more severe like pneumonia, so your patient doesn't have fever, doesn't have pleuritic pain, worsening shortness of breath, things like that. So if you can put them in a category of common cold, of bronchitis, then understanding the natural course of those syndromes is very important for a healthcare worker and for when you do that counseling for your patient, right? Because oftentimes when people end up coming back to or asking for an antibiotic is because there is a persistence of symptoms, usually because there is persistence of a cough. And so it's important to understand that both with a common cold and or with bronchitis, you can have a post-viral cough that can last for 3 weeks, sometimes up to 3 months. And so carefully explaining to a patient that, they can expect, some of those symptoms to just not like go away all of the sudden, but sometimes for people, those symptoms can linger for a little bit longer. And that so long as there aren't any other warning signs of something more serious, so if there's no fever, for example, then, it can take a little bit for your body to like fully get over one of those things. I think one thing that is very important to do right, for us as clinicians is that when you see a patient with, that's coming to you with some type of respiratory complaint, it's very important, you take in all of the details of what they're saying. You ask things like, are you having a fever? Are you having shortness of breath? Are you having pain when you breathe? That you gather those symptoms. And it's very useful that when you examine a patient, you are actually going over what you are finding, right? So if you look at their throat, you can say, okay, your throat looks a little red, but I don't see any exudates, or you can tell them whether their tonsils are swollen or not. That when you listen to them, when you auscultate them, you say your lungs sound clear, or, if they don't sound clear, like different story, right? But if you're finding a normal exam on a patient, that you tell them that, right? Your heart rate sounds regular to me. Your lungs sound clear to me, because then you use that information for your counseling. And then when you do your counseling, it's very important to prepare a patient for what to expect and never minimize their symptoms, right? It's important to not say things like, oh, this is just a cold, or this is nothing, because the lived experience of a person with a cold, and we've all had them, it's not fun. So you can say things like, your symptoms are consistent with a cold, or your symptoms are consistent with bronchitis. Your physical examination is normal. This to me suggests that all of your symptoms are likely caused by a viral infection, and antibiotics are unlikely to help in alleviate or make any of those symptoms better. And then offer things that can make those symptoms better. So if I may talk about what those things are, things that, have actual evidence and RCTs that can help with the symptoms of a cold or bronchitis. So for symptoms of a common cold, actually saline nasal spray has been shown to reduce the duration of symptoms. So the other thing that can also help is honey. In however preference, I like it just like a spoonful of honey. So honey can also help with sore throat, can help with a cough. For symptoms like body aches, taking Tylenol or ibuprofen, if patients don't have a contraindication for those things, can also help. And sometimes, if cough is bothersome, particularly at night, that's when using something like a cough syrup for a discrete period of time can also be helpful. And so again, that combination of advising, telling your patient what you're finding, counseling on what to expect, right? These symptoms can take, 3 weeks, sometimes up to 3 months to fully get over a cough. And then offering things that can actually help, and emphasizing that an antibiotic will not help.
Okay, I really like all these recommendations. I'm going to go back to one of them. So taking the honey, I'm assuming you want to take that straight and not mix it with anything. I'm assuming the viscosity is important.
Yeah, it's honey has been studied in like different formulations. And so different formulations have seemed to work. I personally like it like that, undiluted, because I personally think that you do find it a little bit more soothing when you take it that way.
Okay, and then going back to taking antibiotics, often the harm is underappreciated, and it's often the second most common reason you go back to the hospital because of an adverse drug reaction. Is that correct?
That is all absolutely correct. And I think, again, there's interesting research into this, right? Because sometimes, we in health, as a clinician, you want to help a patient, right? And sometimes there's a perception that the patient expects for you to give them an antibiotic, and the antibiotic is just essentially that something, an avatar for what will make you feel better. And there's actually research showing that, reassurance is what reassurance is what patient needs and wants, actually. So yeah, and the thing is, people often forget to or fail to see, or don't know perhaps, what you were just mentioning, that an antibiotic is not without harm. They are a very common cause for going back to the hospital with an adverse effect. Often those adverse events can take the form of an allergic reaction, but they can also be things like, diarrhea, vomiting, inflammation of the liver, and some even more severe reactions, like when you think of something like Stevens-Johnson syndrome, or TEN, which stands for toxic epidermal necrolysis, and DRESS, so the very severe type of allergic reactions. And then this has been studied on the outpatient setting, but also on the inpatient setting. Oftentimes people can have acute kidney injury, liver injury, and so antibiotics are not without harm. And so that's an important point that you have to make when you're counseling your patient, right? When you say, again, you go back to to what they have, the syndrome that they have, and you counsel and say, an antibiotic will not make any of your symptoms get better and carries a lot of harm for adverse reactions or even more severe things like C. diff, right? C. diff associated diarrhea.
Yes, effective, empathetic, and clear communication is extremely important to weigh the risks and the benefits of any intervention. So when thinking about some of the most exciting developments, what are in the works, or what are in the pipeline for treating infectious diseases?
Well, I think it really depends on the infectious disease that we're talking about. If we are thinking of like in the space of respiratory viral illnesses, there's been we certainly need more antivirals, I guess. I think that the options there, perhaps this is more like of a call to we need more research in that space, right? I actually, have really found studies into these non-pharmacologic options for treatment, again, such as the saline spray, and things like that, to be very to be exciting, right? Because it shows you that sometimes you can do these things that are more simple and that can help your patients. I think that perhaps recognizing the advancements in immunizations, and whether that's in the form of vaccines, or in the form of monoclonal antibodies, is also something that I find to be very exciting, right? Because even better than treating an infection is actually preventing an infection. And so I think that that's where I've been most excited about for what I've seen, is that it's one thing to study a vaccine or a monoclonal antibody in a controlled population. But when you see the real world, studies once countries or provinces roll out these products, and you see their impact, I think that that's what I have actually been more excited about.
Well, looks like there's a lot to look forward to. I just have one last question for you. What advice would you give to a student interested in pursuing medicine?
Um, I think I would say follow your dream, I guess. First of all, be prepared to study, to study and work for long hours. I think that whatever career you're interested in, right, to think about what is your purpose in life and what is the purpose of what you are trying to achieve through that career. I think that if you have the opportunity to rotate with, or to visit, to shadow with people in the field, that's also perhaps something, very good in terms of, opening yourself up to what medicine is, because medicine is a lot of things, right? And so there's such variety in practice and in what we do that, if someone is interested, they should be reaching out to more than one person to try to see different lived experiences in medicine, because it's a very broad field, and there is a lot to do, right? And so that you could get a feel for it.
Yeah, I like that. So shadowing and reaching out to others in the field to get a broad understanding of what you're getting involved in.
Yeah.
Well, thank you, Dr. Rosa, for your insightful discussion. And for the audience, thank you for joining us, and see you in the next one.